Hello, everyone, and welcome to this SPACE webinar. I am Hannah Tebeka Azriel, and I will be your host and moderator for this webinar. We are honored to have Dr. Latowa and Dr. Konstantin Frank here with us tonight. They are going to speak about the lips, telling us everything there is to know about the lips, and telling us about how to use the Revaness range on this specific area. So thank you so much to both of you for being with us and participating into this webinar.
Hi, Hannah, good to see you. Good to see you, Olga.
In order to give a bit of time to everyone to connect, I'll just start by introducing both of you. If Olga, you can just switch slides.
Yeah.
So Dr. Olga Latowa is an aesthetic physician from Vienna that combines an artistic vision with medical expertise.
Not working.
It's not okay. It will arrive. Like just keep trying. I think sometimes it takes a bit of time to be able to switch slides. It will come. Okay, great. Dr. Latowa is known as the Lips Queen of Austria, and she specializes in personalized care and natural enhancement techniques that respect each patient's unique features. Next slide, please. Dr. Konstantin Frank is a plastic surgery resident from Germany that received training at Harvard University and Ludwig Maximilian University. His practice merges surgical innovation with academic research, and his unique approach combines biomechanical expertise with clinical investigation. So I will just tell you a little bit how this webinar is going to go. It will last approximately 1 hour. Will be held in English. Everything is being recorded, so don't worry, you will receive in 2 days the replay of the webinar, and you can watch it as much as you want. It will also be subtitled in Spanish for those that don't fully understand English. And don't hesitate to ask all of your questions in the chat or in the Q&A section. Just know that we will proceed with the presentations and then answer all of the questions at the end of the webinar. So I will now let Dr. Latowa start with her presentation. Thank you everyone again for being here, and I will see you at the end of the webinar.
Thank you, Hannah.
Just a little disclaimer in between. And we talk about lip injections. So imagine there are 3 new powerful products created especially for naturally defined lips. 3 new products from one company, from Prolinium. Today I'm here to share with you my results from 3 months of testing and using these products on actual clients. I have summarized the best applying techniques for all 3 products. So my name is Dr. Olga Latowa, and I'm the founder of the Doctrice Clinic in Vienna. My patients are between 18 and 80, having different lip desires and needs, which we cater to use our beauty technique. And I'm joined today by my very dear colleague, Konstantin Frank, and he will take over in the middle and we talk in the end about all our expertise and experience. So beauty, wait. B is for beauty concept for lips. E is for elevation of lips, anatomy of the lips, usage and product positioning, techniques for injection and inspection and outcome assessments. These are all the points we're going to talk about today. So let's start the overview. Lip injections are among the most popular cosmetic procedures worldwide. Everybody knows that, so everybody wants to learn it also. Social media and shifting beauty standards drives the popularity, and knowing the medical principles ensures natural results that suit individual facial aesthetics. The role of symmetry. I'm very sorry, my voice is a little bit down today, so please forgive me if I lose it for a second. Facial asymmetry is a key in aesthetics, with studies linking to it to perceive attractiveness. The golden ratio, we all know it, it's 1 to 1.6, guides beauty analysis, including lip proportions and positioning. Me personally, I love the 1:1 ratio, but it's a question of taste, personal taste, and also what suits a patient more and what also is achievable in a sitting or two. So lip enhancement aims to achieve symmetry with features like the nose, eyes, and chin. Projection. This is like the Ricketts line, we all know it. If the line gets touched by the upper down lip, chin, and the nose. This is an actual patient of mine, photographed immediately after the lip injections. Of a beautiful face. Now I'm showing you like the perfect proportions of the three parts of the lips. And I have to say, of course, we all know that this is like the most achievable proportions. But what will we do with patients if they don't have it, if they don't have enough chin, if the chin is much too big, or if the philtrum is way too long? And of course, you can include surgical procedures, but not every patient wants them. So for myself, I know if I define their lips and I try to imitate, like how to say, simulate proportions with a lip job, they feel much more confident, and it's also already a big, huge help and makes them shine and feel happy. So never stop without the lips. Okay, gender differences in a lip aesthetic goals. There are like many, many papers around about it. I have to say, I did one study for a huge congress, and me for myself, I have to say the male lips, the most beautiful ones, are actually very similar to female lips. But the male attributes are getting covered like by jawline, noses, and all this other stuff. But if you look at a perfect male face, with beautiful lips, they're all actually very, very female. So I'm not scared to do male lips in a female way, but it also depends on your taste and expertise. So this is like a very, very little outlook of different shaped lips. You see, like the first lip has a little down, or a little bigger down lip. Here we have like a 1-to-1, but a wider down lip. This here, the third lady is, the upper lip is more prominent and covers the down lip. And this patient, you see also the down lip is almost disappearing, but there are many, many, many more variations. What we want to achieve is always a symmetry. We'll come to that. So now we have the lip shapes and aesthetics, I'm sorry. So full lips, thin lips, and Cupid's bow. This is also for this really, wait a minute, just a second. Yeah, okay, so most of the people want to, sorry, I'm gonna skip this one. Okay. Yeah, so I mean, as you know, there are very, very many and different variations. I don't want to talk about every in particular, but I'll show you later what we're gonna do about it, okay? So, lip symmetry. Lip symmetry ensures both upper and lower lips are proportionate, aligned, and even in shape. Lip volume. Access natural lip volume and desired enhancement while maintaining harmony. I'm not a big fan of volume because volume for me suggests always something like a little bit too blown up without a contour and without a nice shape. So before I go towards volume, I always try to get symmetry, definition, and proportion. Volume comes with time from my experience. And lip shape is for me the most important thing in creating lips, because even a thin lip, when she's well defined and shaped, is beautiful. Focus on choosing your guess. And the most important thing, you see it on the side, it's a Cupid bow. We'll talk about it later. The Cupid's bow is this little tiny thing with these two projection points for the vermilion border. And if you define it, it always gives the lips a nice glow and also very usefulness. Sorry, guys, just a second.
Olga, I think we can switch now to the anatomy presentation.
Okay, cool.
Perfect. I'm more than happy to jump in at this point, Olga. Thank you so much for setting the tone and the pace for this webinar. So obviously it's all going to be about lips today. I think we had a very catchy title, and I'm very happy that we have more than 300 people who joined this webinar, probably late in the evening or even after a long working day. So what I would try to do the next couple of slides, minutes, whichever way you want to talk or look at it, is that I'm going to try to explain a little bit about lip anatomy. And lip anatomy really kind of links back to their very much function. It links back to the classical anatomy as we know it, like the histology and the layers, which we're going to discuss, and also the biomechanics of the lip, because the lips are obviously in the center of the human face. And they're one of those, what I call epicenters of mobility. We have two epicenters of mobility, one in the eyebrow, where you have elevators and depressors kind of acting on the positioning, especially if you're medial eyebrow. And then the other one is the modulus. And the modulus obviously is the most lateral part of the lips. And this is where we have a plethora of muscles inserting into this very much region. Now, they obviously have very big function and role in articulation and speech. If we wouldn't have a very precise, at the end of the day, functioning of the positioning of our lips, we wouldn't be able to articulate ourselves and speak with each other as we're used to, and as this has evolved in the course of evolution over the last millions of years. Now, something that we kind of often miss is the huge impact of sensory perception of lips. This is, I think, a very big feature of lips that we do possess. And this is something where, if we think about the function of lips, we're very, very, very fast at this idea of complications, because patients often complain that the perception of the lips is altered after lip augmentation. We're going to discuss this later on, how you can avoid this and how you can get a more natural result. Now, obviously, not only in terms of articulation and speech, but also in this whole idea of expression and communication, lips play a very important role. And for me, this is something we really kind of need to communicate to our patients as well. Lips go both ways in terms of expression, communication. Ultimately, we do have a vermilion border, because this allows for a better understanding of the positioning of our lips when we speak to somebody else. So this increases our nonverbal communication skills. But on the other side, also altering our lip anatomy can give nonverbal communication. So obviously, there are certain traits that are communicated if lips are increased in size and volume, which up to a certain point might be seen as preferable, but after this kind of can also go in the wrong direction. So something we will cover later on as well. Then obviously, function of lips is food and drink intake and protection of our oral cavity. Now, those are two things we're not going to cover too much today. But what we're going to cover is definitely also the idea of aging of lips. Now, this for me links back very much to the anatomy of it. And if we kind of think of the patients that consult us on a daily basis, as Olga just said, they might be from 18 to 80. And this is a very important thing, because I don't think that you can beautify or make something more beautiful without understanding the underlying aging of a certain region. And this goes both ways. So we have to understand what is actually happening as we get older in our lips. And interestingly, one of the main signs of aging in the perioral region is an elongation of our philtrum. Now, this elongation of the philtrum goes hand in hand with also a loss of definition of our vermilion border. And this you can see, I think, quite nicely right here in this ChatGPT generated person. At the end of the day, I asked ChatGPT, or actually a different AI, to create the same person, but in different stages of their life. And what it did automatically is that it kind of really integrated those changes that we see in the lips. They become thinner, they become more atrophic, also they become a little bit more wrinkled itself. So the tone of the lips is not the same as it is in young ones. And many of those reasons that we can find are actually kind of found in anatomy. You can see right here a histological slide of the lip, and on the left side, it's the histological slide of a young lip, and on the right side, it's a histological slide of an elderly lip. And what you can see, which is very striking to me, is this insertion angle of the orbicularis oris muscle right here. So this, obviously, we still all remember histology, is the orbicularis oris muscle inserting right here at the vermilion border. This is where your mucosa actually stops, and we then kind of continue with the normal epithelium. And you can see that the angle in this young lip is shaped like a J, right? It's shaped like a J, and it has quite a big angle right here. However, if we look at the younger lip right here, we can see that the insertion angle is much more shallow. And this actually explains why the nice definition of our vermilion border in younger patients is so much more prominent, because the muscle has kind of a much more perpendicular insertion into this vermilion border. Also, at the same time, we do lose a lot of subcutaneous fat in our lips. And this idea that this is just skin and then we already have muscle and mucosa is outdated. You will see this later on. So it becomes really important to understand that as we get older, we also lose subcutaneous fat, which is on top of the orbicularis oris muscle. So this is something Olga's gonna kind of get back to later on when she speaks about her injection techniques, because this is where, when I also personally started to inject in the subcutaneous plane, got much better results than previously. So what does a lip constitute of? What are the different elements? And to be all clear in the next couple of minutes, I think it's really important to go over the topography once more. There are many, I would say, misconceptions or wrong wordings when it comes to the lip. If we start at the upper part, this right here is our philtrum margin. The philtrum margin is basically created by insertions of collagen fibers from orbicularis oris muscle straight into the skin. So some people hypothesize that there's a kind of loss of muscular continuity in this median line. This is not the case. It's just really fibers that insert right there from the muscle going into the skin. You will see later on. And then at this intersection between the vermilion border and the philtrum margin, this is the so-called Glogau-Klein point. This is what we can use for our advantage when we want to emphasize our philtral definition. Now, then right here below the vermilion border, we have our dry mucosa, which then becomes wet at this wet-dry border in the anoral direction. We do have tubercles in the lip. Usually in the upper lip, we do have 3 tubercles. In the lower lip, we have 2 tubercles. And then also at the lower margin, we do have a vermilion border, which kind of creates a separation between our dry mucosa and the normal epithelium. If we look at it from the side, you can see that on top of our orbicularis oris muscle, there's always a sheet of fat. There's always a subcutaneous fatty layer in both upper and lower lip. Now, this becomes really important later on when we speak about the layered anatomy. Then there is obviously the big question where our artery is running. And you can already see right here that there's not only one labial artery in our upper and lower lip, but it has actually many branches. And this is something very important and dear to me to communicate with you guys, that there is not only one superior or only one inferior labial artery. This one is one of the most vascularized regions. And if you do surgery, it's quite bothersome. For example, if you do a bullhorn lift, because everything bleeds quite heavily if you don't use epinephrine with your local anesthesia. But also if you inject, this is an area prone to bruising. This is really important to understand, that it's not only about kind of missing out on this one artery that's there, but you need to be aware that there's actually a rich plexus of different arteries. We looked into 2 different, or actually we summarized 2 our findings in regards to the superior and inferior labial artery in 2 papers, which have been published. One is already out 8 years now. This is kind of one way to check that I'm getting older. It was called Distribution Pattern of the Superior and Inferior Labial Arteries, Impact for Safe Upper and Lower Lip Augmentation Procedures, back then published in Plastic Reconstructive Surgery when they were still willing to go into some cosmetic direction. A couple of years later, we revised this with ultrasound, and I'm going to walk you through those papers. Now, the first paper, we looked at the positioning of the artery, and can be either subcutaneous, intramuscular, or submucosal. So you're already seeing that there are 3 different positions. Now, interestingly, in 80% of the cases, the artery is running in the submucosal plane, which means that this is clinically right. If we palpate from an anoral point of view, we can feel the pulsation, we can feel our artery. And in 18% of the cases, it's running intramuscular. Now, how can it run intramuscular when it's such a thin muscle? Quite simply because of embryology. We have a sheet which forms the orbicularis oris muscle. And it's basically 2 sheets which then come from lateral to medial to fuse. And sometimes the artery is kind of caught by the 2 planes of the muscle and then engulfed. So it's kind of like in a sandwich. Then in 2% of the cases, you can have a subcutaneous course of the artery, which means that it's quite superficial. Very rare, but it can happen. Now, it's not obviously only a question about if it's superficial or deep, but for me, what was much more important was to understand whether it's running cranial of the vermilion or the lower lip, obviously caudal of the vermilion border, or actually within our dry mucosa. And this is why we performed an ultrasound-based study. A couple of years ago, we published it, as I said, in ASJ 2020. And we kind of showed in this study that in 100% of the cases, the labial artery is found in or within the dry mucosal part of the lip. So it's not cranial or Karloff or vermilion border. And interestingly, in those lateral positions, the artery was not always yet inside what we usually call the lip. The reason for this is that the artery has to kind of find its way and fiddle into the lip itself. And this is why, especially in those lateral parts, when you start contouring, be aware that the artery might still be quite cranial or close to your insertion point of your needle. So something to be taken care of. Those are some dissections I performed for this webinar. You can see quite nicely that if we flip over the skin, we can see some fat. Now, very interestingly, here you can see how the fat is kind of interrupted in a way, and fibers of the orbicularis oris muscle are inserting in close proximity to the skin. Now, if we zoom in a little bit more, you can see some small vessels. And those small vessels are ascending branches already of the labial artery. So they run in close proximity to the philtrum. And this is something we're going to discuss later on, why I think that injections into the philtrum can be dangerous. Now, if we flip over this fatty tissue layer, you can see this right here. We can see parts of our orbicularis oris muscle. The fibers are radiant. If we split open this muscle, and this is really important that you actually have to split it open to look into the submucosal plane, you can see the labial artery right here originating from the modulus and going towards the philtrum. This right here is the superior labial artery, and you can see how on top of the superior labial artery, we do have a venous plexus right here. Those are some small, tiny veins. And this is one of the main reasons why bruising in this region is so common. You can see this quite nicely here, but even if we scroll further, you can see how the labial artery, so up here is the nose, right? Here's the modulus, how the labial artery then moves in a median direction. And right here, this is an angular artery branch, which means that the facial artery goes to the modulus right here, splits off a superior labial artery. And from a pure definition point of view, this is where the facial artery actually stops being the facial artery and then continues in some instances as the angular artery towards or along the nasolabial fold. Here once more to show you topographically a little bit more the course of the artery. And this is just to show you that a submucosal injection can cause actually some issues. I would say that necrotic or necrosis after vascular occlusion in the lip is very, very rare. I've seen some lips which turned white, but which were easily fixed with high lace because we have so much arteries going into there. So having a necrosis, as you might see in the glabellar region or dorsum of the nose, is very, very rare, but it can still happen. So be aware of this. Another thing which I want to speak about very quickly before handing over to Olga again is that the lips are a region of the face which moves a lot. We touched on this when we spoke about the epicenter. Now, the muscles that insert here and exert pull, strain, and stress on the lips are manifold. As elevators, we have the levator labii superioris aliquinasi muscle, the levator labii superioris muscle, levator anguli oris muscle, and the zygomaticus major muscle and risorius. As depressors, we have the platysma, which continues as depressor labii inferioris. We have the depressor anguli oris, and obviously the mentalis muscle, which all alter the positioning of our lip. So this is a region which makes it really hard for any HA filler to kind of step up to what we expect from it, right? The reason for this is that we do want to have a filler which is soft. We spoke about perception and sensory perception, but we need to have a filler which withstands all of those forces and doesn't migrate. So this is something very important to understand. And you can see this in this vector photo when somebody's blowing a kiss, how much movement is going on right here in the perioral region. Now, one last thing that I'm going to speak about before finally handing over to Olga so we can all see her beautiful technique is that we do fumble with the attractiveness when we change the lips, as I think in no other region of the face. This is really important to understand that you can also disfigure patients. And personally, we've conducted some studies. We created different upper to lower lip ratios with Photoshop and showed those photos to subjects. And while they looked at those lips, we tracked where their eye was looking with an eye tracking device. This was published also in PRS's paper of the year. And what you can see is that in those heat maps, the gaze starts to focus on the lips only once you increase the upper to lower lip ratio greater than 1.6 to 1 in Caucasians. So obviously this is slightly different in different ethnic groups, something to be considered. But it's not only the upper to lower lip ratio itself, but also the volume. You can see that as the volume increases, the gaze, which was formerly in this classical triangle configuration between eye, nose, and mouth, really shifts to the mouth right here. And this is something really important, I think, that we need to be aware of, that if you start fumbling around and augmenting lips, which is perfectly fine, that you really need to keep at the back of your mind that by changing the anatomy, you're changing the perception. Last but not least, just a couple of words on complications. Use the right product. Those are photos from my former boss in Spain, Kai, who basically, I would say, really specialized in the treatment of lip filler complications. This is not HA-based lip filler, but Aquamid, and you can see what it does to the soft tissue in the human lip. It's horrible. It becomes granuloma tissue. It's really hard to excise, and fixing those lips is very, very hard and takes many steps. So choose the right product. Make sure that you understand the product that you're using. And I'm more than happy to hear from Olga how to utilize the whole Prolenium portfolio for lip augmentation. Olga, the stage, or rather the screen, is all yours. Thank you so much. I think you're still on mute. Perfect.
So I'm back. Thank you so much for your presentation. Thank you so much for the anatomy and the section pictures. They've been amazing. I miss it. Super
You
nice.
should join one day.
I'm coming back, I promise. So for me, there are 3 key factors for choosing the right product before I choose the technique, actually. So the first one is the tissue quality, and this is always the primary determinant for product selection and technique. And it depends on the tissue type. There's loose tissue versus tight tissue, and they require different product choices. And the product selection, this is the most important thing, because you have to know which type of tissue can hold the product you're injecting. And we are talking about the 3 new products of Prolenium. The first one, oops, wait a minute. The first one is KISS, Ultra Plus, and Outline. The Ultra Plus is for the lidocaine, so they're all with a very nice shot of anesthesia. We start with the guidelines for appropriate product use. KISS is a very, very nice and soft product. It's very nice for beginners. If you want to try out, if you want to play a little bit, use small amounts. It's also very nice in dry lips in need of hydration. Also in very big lips, in well-defined lips in need of highlighting features. Also, if you have a lot of loose tissue like me or like very old people, and you don't want to produce nodules and stuff like that, because if you have a lot of thin skin on the lips, you have to go very, very soft, like almost like watery. Otherwise, you produce lumps. The patients will not be able to massage out. And Ultra Plus is an amazing product. I'm really, really highly in love with it. It's very good for firm and strong tissue. Also in need of volume and projection, especially young patients in need of volumization, because you all know young patients want a lot in a short time, but the tissue is not so stretchable as like an older patient. And also in smaller lips, if you want to stretch the tissue as much as possible. But in smaller lips, I always advise to be very, very, very careful with the amount you inject. A small lip can never hold 1 ml. So I always do maximum 0.5 ml per sitting, sometimes less, and a second session in 2 weeks. And my absolutely favorite, I don't know if you're allowed to have favorites, but I have one. It's Outline Plus. And this is an amazing product because it really stays where you place it. So I mean, I tested it for now longer than 3 months. And if you have lips without definition and contour, if you have strongly asymmetries, and if you have no Cupid's bow, you want to create a definition. So an amazing product. So And I developed like a specific product positioning for different lip profiles. Kiss injection, I recommend a superficial and retrograde injections. I will show you later. Thin lines or macro droplets, and also massage it. You see, I mean, you can, I mean, of course, you can start wherever you want, where you feel comfortable with. I like to do the entry point here, going the needle with the needle forward and then retrograde inject. Very, very superficial and very thin lines. And after that, I go and then massage it softly with my hands. If you have a lot of tissue in this part, you can do like tiny, tiny drops and also massage it softly so it integrates before you leave the patient to go home. Yeah. Ultra Plus injection, I would always recommend a deeper layer. And as I said before, always in a stronger tissue. I would never inject Ultra Plus in like loose tissue in elderly patients. So deeper layer, if enough space, then micro droplets in the red lip, if you need it down there. If not, just the layers from above. And I always start in the vermilion border and do retrograde injection. Sorry for my voice, really sorry. Careful in the peristomal zone, this is here. Otherwise, because most of the time the skin here is much more loose before it turns to the wet border. And always massage. So this is like an idea of how to do. You can also do like also fan a little bit more if needed, depends on the lip you start with. And never cross this line because this part of the lip is mostly very, very thin from the skin tissue. An outline, I recommend to do really short fanning technique, micro droplets, but not too superficial. You can also do lines if needed, like on the corners, or if the lip can hold it from the tissue. And always focus on the Cupid's bow because it gives every lip a very, very useful and cute appearance. And this is what actually every woman wants. So strategies for combining products. This is actually my favorite thing. I love to combine products because when I started to do lips, I always did one session, the first session with one product. And after that, like when they come back after 6 or 8 months, I did the next product. But why should we do that if you can combine them in one session and get like the most of the outcome in one session? So lips with no defined contour and loose tissue in the peristomal zone. What I said before, you can use the contour with the outline and fill the folds in the peristomal zone with Kiss, for example. As you see here, she has like a really strong tissue above and she needs a nice contour. The Cupid's bow is a little bit loose and not defined. And you see what I did. I focused on the Cupid's bow, made it more round. And all this loose tissue I filled up with Kiss. Beautifully. So lips with no defined contour and flat and seeking projection. I recommend contour with outline and voluminize with Ultra Plus. And you see a mature patient with like actually an inverting lip, but not so much loose tissue. It's a perfect candidate for Ultra Plus and contour, as you can see. So we have some case studies and before and after examples, and we did a beautiful, beautiful photo shoot with 4 patients in my practice, and we used all 3 products and combined them as well. This is patient number 1. She's 41. It was her first time lip filler, and we used Ultra Plus and Kiss. And I show you like in detail. What's that? Oh, that's a video. So as you can see, I do tiny, tiny, tiny retrograde injections, what I showed you before, just to define the contour. And you see she's having a lot of loose tissue in the peristomal zone. She also has like, how to say, undefined contour because of her pigment. She has some very cute wrinkles. Not wrinkles, how do you call them? I don't know, but you know what I mean. So, and as you can see, I'm very, very conscious where to enter the needle. I'm always up a little bit down the vermilion border. And I always stop before I take the needle out, not to produce too much hyaluronic acid in the vermilion border because it makes the new mustache migration kind of. And here I hydrate As you can see, with very, very thin superficial lines. And afterwards, I massage it. I think, and then pictures later, we'll see that she had a little bit of asymmetry. I tried to correct. I hope she looks happy, huh? Yeah. Next. Okay, you can see here from the side. I think this picture, let me see, I was directly after. So there is a swelling involved. But you see what it does with the proportion. And it gives you more shine and more volume. And it seems hydrated right away. I have to say, every patient you see now, I saw them after 2 weeks for a little touch-up, because we had 2 patients with severe asymmetries, and or if somebody's having an asymmetry, I always try to correct it after a couple of weeks, because the tissue follows needs much more. And you can see here, this side is a little bit more up and this a little bit more down. So I try to correct it. So you see this side appearing a little bit more swollen, because I did here a little bit more afterwards. Let's check how it looked after. Yes, from this side. Very good. Yes, outline it. Okay, this is the second patient. She was 40 years old, also first-time patient. As you can see, also a slight asymmetry, a lot of loose tissue on the peristomal zone. Beautiful lips, as you can say. But you can always improve something. So I think a video coming. So also the same beginning, I tried to create a Cupid's bow. This is my favorite thing to do. And create a border and contour, like modified contour. I do really, really very tiny amounts of product, because I think less is more, and especially for women over 30, 40, it's much nicer to enhance like the things they used to have, and to give them the volume and glow what they had like when they've been 18, because every lip shrinks and becomes less as they used to be. Actually, it was a pleasure to work on her lips. Okay. So. Tiny, tiny, tiny lines. And also hydration on the peristomal zone, as we saw before. And you can really see how the product spreads, because it's so beautifully liquid. This was Kiss on the inside. So. And you see here from the side, and so it's a very minimal result, but it makes a huge difference. That's what I think. And this is like this typical swelling after the injection, but we will go away, and I hope you will see that the asymmetry is nicely corrected.
So this was done with Kiss only, right?
No.
No, this was a combination.
Yeah, it was also a combination, because the border needs a little bit more than Kiss. Yeah, I think with Kiss, and you cannot define borders. It's like really perfectly, if you like, restore tissue, because if the lip is like really like a rosin, you can blow it out with Kiss. It's beautiful. But I will be very gentle on the borders, because from my experience, more liquid fillers don't stay in the position. And you see, it's also, she's also very, 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 it's very nice when it's very good.
And very beautiful with her chin and her
And
tip
it's,
of
I mean, you wouldn't, if you don't know it, you would not tell that she had done something. And this is like what I try always to achieve. And this is actually the daughter of the first patient we've seen. And I have to say, one of the most difficult lips. And of course, she wanted more. And so her mom was really happy that she could come and I could do her lips. But as you see, really full lips, actually, you know, and without doing anything, she feels, she looks like they're already filled. So you have to be like very, very careful what you put in. So I choose Ultra Plus, and I told her that it will take time to stretch her lip and to because she showed me a picture what she wanted to achieve, a totally different lip shape. Anyway, so I told her it will take time to get there. But I also told tried to you see, it's actually a totally full lip. So I tried to create a border and correct her M. She has like a little M shape. So she has like these beautiful, beautiful pillows. 1, 2 here, and they're kind of cutting in the upper lip. So I tried to correct this part and give her more volume and to the peristoma zone and define the border and also create a little bit more of a cupid's bow, what she didn't have. But you see, like these are like really droplets, and she blows up immediately. So you have to be really, really careful with this type of lips because
this is why, and Frank Rosengaus gave me a little bit of a hard time at IMCAS about this, but I think he was right because I formulated wrong. But this is why I said you need to be a fast injector in the lips. For me, it's really important that you have already in your mind what you're going to do and don't go by trial and error. I'm going to put a little bit here and see how it works. This for me is not how I get good results. What you need to do is exactly as you showed before, have a very step-by-step detailed outline of how you're going to tackle the lip. Because once you touch the lip, in some patients, especially, I feel more in younger ones than in elderly ones, it can blow up. And
yeah, sometimes you see it spreading. It's just like really see you put it somewhere.
The swelling is going everywhere. You don't know if it's tissue reaction or if it's actual HA. So this is, I think, really important. And then also to trust a product where you know, because sometimes I don't know how you do this with your patients. For me, especially the ones that get a lip treatment the first time, who are ready to go down this road now, because it can be the most stigmatizing treatment that we have. They're really like after the treatment are like, oh my God, not oh my God, but is it going to be that big? And then you can calm them. And this is really important, I think, that you have a product at your hands that you can trust, that the swelling will go down, it will not retain too much water, that you can comfort your patient.
Yeah.
Do you have
And
any
also it's very, very, very important, sorry, very important to use very tiny amounts. Don't go on the, you see from the side, it's also very, very nice in the profile. But I would love to see her a couple of times because I think I can bring her lip like in the way she wants with a couple of sittings. Yeah. But it makes her like more happy and more, it's like she has beautiful eyes, and just to see if the lips are getting more volumized, it harmonizes the full face. Also the profile. This is my last patient.
challenging case, I think. Challenging case.
The funny thing is, you would say, because she is a little bit older, 84, I mean, that she would have loose tissue and kind of, when I thought she has loose tissue, but from my experience, I know it is not a loose tissue. She has a little bit of fold. She has a slight asymmetry, as you see. This side is going like much more down, and also the apex of the right side. So, but from my experience, I knew this tissue is fooling me, and she can take a little bit more. So and also for the asymmetry, so I choose Ultra Plus, and it was actually the right choice. You see? And here you see, I focused on the down lip, and down lip was like she was not really working with me. So I really put a lot of work in the down lip, and for the first outcome, I'm satisfied. But in the next round, I would totally also focus more on the down lip because there's less tissue in the proportion that lies in the upper lip. And as you can see, I filled this gap because she has this slight M shape here and a loose tissue. And this is actually was my playing ground to get the red lip a little bit more pronounced. Yeah. And she also actually, normally I would also use some Botox on this side to bring, over there, just go, to bring, because she's pulling up a little bit, to bring it down a little bit. And as you can see, I couldn't bring the asymmetry up in the first round, because I always say there's 3 types of asymmetries. The first one comes up in the first, you can manipulate in the first sitting and it stays there. The second one needs a little bit more treatment, and with time you will get there. And the third one, you will never get the symmetrical with the other part. And she has, I would say type 2, because I saw her later and I was able to correct the symmetry a little bit more. And I think with time we would be able to correct it completely. But maybe we'll see it later. And this is a very natural result, because she was really concerned how she will look, because she's working in a public area. And this is what.
But it softens her overall appearance a lot.
I think also that it's like nobody would tell, but it makes her more fresh. It makes her more hydrated. Yeah. And you saw it on the other picture. What I was she has like a tiny light reflex, you know. And if you get the light reflecting on the lips, then they shine much more. That's what I'm always looking for when I create lips.
The photos are very standardized and beautiful, but for our viewers, you can actually zoom in if you go back once and maybe to the front view and see how much has changed on this lips. It's incredible. Also, you can see the fine lines improved a lot on the upper lip. So beautiful.
It's a very, very, very elegant result. So let's talk about thin lips. Thin lips, we have also it also always depends on the tissue. And I have three patients of mine. This one in the middle was one of the trickiest, because as you can see, her light reflex lies way above above the red lip. So this result was not immediately like after the first sitting. It took me a couple of years to get there, because you need a really strong and really protective filler to.
Olga, I think this is something really important for our viewers, and this is also something this is not a one treatment result you're showing here. And don't strive to get a result which looks like this after one treatment, because you will not able to succeed to keep it like this. You need to build injection by injection. Only then you have a matrix which doesn't overexpand and causes your product to flow around and to migrate. I think this is something I learned from you, Olga, which is very, very important. This very much patience that you need to have in your patience, one with C and one with T, that this is not a result you get after one injection.
Yeah. And if you look at the left and on the right patient, what you see immediately is this loose skin. And if you see loose skin, then be happy. Then you can work, because there's a substance you can stretch. If you see this kind of lips, prepare them. It will take at least two years to see the result they all achieve they want. So what I always say, to calm them also down, that you get a definition immediately. That's what you can do to get a proportion, and that should be like the beginning, how you can hold the patient. So thin lips, big lips. For me, the big lips are kind of one of the most difficult lips to treat, because they are already beautiful, they are already big, and it's so easy to mess them up and to make them look vulgar, and this is what I don't want. So if I do big lips, I work very, very flat, and I just focus on the shape, on the cupid's bow, and how to enhance what they have actually already. And as you can see, I play with the cupid's bow, yeah. And it makes a total different appearance. And hydration. Big lips, always in need of hydration. And this is actually a very good, example that how it looks from the profile. If you work little by little and very flat. And I always say, never let the perioral area out of sight, because It's for me, the lips and everything around is like one picture. And I normally never use 1 ml in one lip, so there's always something left. And so if you do the lips, you can also treat these lines, or you can treat the corners. And the patient is really, really, really thankful and satisfied if you do so and help them around. And as you can see, it makes a lot of difference. Very young patient, very sportive, and really suffering from these perioral lines in a very young age, actually. So this patient of mine, she actually came to me after she was treated with her hyaluronic pen. She had like this really, really hard nodules I had to dissolve. They're really, really hard to get, but we managed. And she never had lip filler before. The hyperkinesis is really, really strong. And I used the tiniest needle I could find and did like really tiny amounts, but you can see it's a huge difference if you treat these lines with the lip. So let's now be talking about inspection, outcome, and assessment. And post-treatment steps, what I would recommend. I always access the lips and touch the lip area with both hands. If they're lumps, I massage them, because the people the patients are already anesthetized, they don't feel not so much anymore. And if I see a lump, I really scratch it in, because the patient would never do it, and if I do it for them, it's better. And I don't care if they get like a hematoma or stuff, but they will be more thankful if you get the lumps out. And I always educate, because lumps are normal. We are working so superficial. It's part of the deal. And it's also part of the patient's work afterwards to massage them. That's what I always tell my patients. I always sit up the patient and go around him. I talk to them and make them smile. And we talk about like nonsense. But if you look at them, I always look at them. Then you see asymmetries maybe or not, and then you can still go back and correct whatever you see. Movement and the line, the peristomal line, is very important for me. Yes, I love them smile. I make them smile, and I always say the lips are actually like a frame for a good smile for the lips. Step 3, apply aftercare. And now we're talking about the best aftercare there is, soft fill. I was able to try it, and it's a recovery lip balm from Soft Fill. I recommend to put it in the fridge, because it has a very, very nice metal tip. And if it's a little bit cold, the patients will thank you a lot. So, and if you don't have this one, order it. I'll use a rich calming cream after the treatment. Sometimes I also use aquaphormoitzurine. It depends what you like to apply and what your patient wishes. My patient can use their own stuff, whatever makes them happy, but this one is the best. So we have my patient, if they have a herpes infection, normally I always find it out in the talk we have before the injection. So if I know my patient is suffering from herpes infection previously, I always give them a subscription. They start to take medications 1 day before, and they continue for 3 days. And all normally helps very good. Yes. And this product reduces discomfort, sensation, soothes and repairs the attacked and damaged skin, and reduces the appearance of redness. Hydrating for sure. Well, actually, I said everything before. And arnica is the key factor for bruises and calming down. It's like Photoshop for what we did with the needle. That's a very nice one. If your patient asks how long will I be swollen and how long will it take to go out, or like to be normal again, I always say the day afterwards is the worst. You're like, please hide and stay at home. And after that, it rapidly goes down. The only problem is what I have with all this management is that the patients fall in love with the swelling, and they're really disappointed after day 4 when the swelling is gone and they don't understand where the lip disappeared. So you have also to educate your patients that it takes longer and that we get one day to the swelling size, but it will take some time. Follow-ups, I recommend if you want to build a small lip, I would never let them come back earlier than 3 months because the skin has to adapt to the filler. You have to, it also, some filler has to get dissolved a little bit. So you get some loose skin, you can fill up again. It's my personal recommendation. And with filler longevity, highly individual. It typically lasts between 6 and 12 months. I have some patients that they're empty after 3 months, and this is a miracle. So you have to really combine fillers, and but that's like maybe 2% of all my patients, and normally 6 till 12 months. And if they want to build it up, I make a plan, which we talk about the size, and if this then yeah, in the beginning, if till you get this size, they can come back after 4 or 3 months. So this is like this is an example of a dear patient of mine, and just wanted to show what's happening after multiple sessions. This was how we started. This is what was the first lip, and this was I think the fourth or fifth session. But you see the huge difference how defined you can work with time. I couldn't achieve this in the one sitting, but the multiple sittings in different fillers, you get there. Also, this was after first sitting, and this one after the second sitting. And actually the second sitting, she came back after 2 years. The filler stayed for 2 years and kind of this shape, very present. So patient filler adjustment. I always tell 2 weeks fully healing. And if they have like complications, if they have nodules and stuff, I always tell them to wait till 2 weeks to come back if they need me, and demonstrate how to massage. I always say never massage like this, and never massage the border. This is like forbidden with my patients. They can scratch it in if they have a nodule, if they, like, but punctually, but never massage the border. This is my advice. And if the lump persists, I normally, if they come back, I check it. Some ones I can scratch myself in, some I dissolve, and some I just really puncture. It depends on how superficial they are, or how big, or how flexible the filler is. And yeah, that's what I spoke before. Thank you, and sorry for my voice.
That's fine, Olga. I think you did more than great. I think for most of the viewers, this idea of combining products, using different rheologies at your hands to create those beautiful results was, I think, enlightening. Probably 1 hour is not enough to go into more and more detail, but I'm sure that we'll have more educational opportunities the next couple of weeks and months to dive a little bit more into this. We're almost over time, so we're gonna answer some selected questions. Isabella Bryant wants to know what product and techniques you used for the perioral lines. What's your preference, Olga? Is it outline? Is it kiss? What do you choose?
I actually do dissection. I go inside the cannula and I dissect like this fibers to pulling the skin down, and then I go with kiss, of course, something really soft.
It's this exactly how I do it as well. Dissection is key if you want to get rid of perioral lines. Something very important is that you're superficial enough, otherwise you don't cut the dermal insertions of the muscle, and the patients will bruise, especially with the cannula technique. For the cannula, I use 22 gauge. 25 from my personal experience is too small to get a good result. And then many people think, well, if I do the dissection, the subcision, I don't need to place HA. This is completely wrong. You get a nice result with dissection only, but this lasts only for a couple of days, 2 weeks. The problem is that the dermal fibers and the muscle itself starts to insert again into the skin. So the filler works both ways. It works to kind of volumize, obviously, but also it works as a spacer so it doesn't scar back. And I think this is really, really important. The question, how often do you inject to get these kind of beautiful results, is probably hard to answer because it is based.
Depends on the tissue, because it's always like it's a hard, if it's strong tissue, really needs more time and more sessions. Loose tissue is easy, loose tissue you fill up and then you create and then you have a follow-up or the next one. But the the tight tissue, this is like really needs time. It depends.
It's probably a lifetime of work that you've just shown there, and I think this is really important for us to understand that you specialize so much into lips that this is decades of wisdom going into this. One last question before we, I would say, conclude this webinar. We had more than 300 attendees over the hour, so thanks to all the viewers. Do you use 30 gauge needles for all fillers? Anna wants to know.
30 gauge or even smaller. I love small needles. Yeah,
Me as
definitely.
well. Me as well.
Because it's like it's you can work fine. I always test how, if I start a new product, I always plunge, I always test on my hand to see how what's coming out, and smaller is better for me.
Yes, what I think is important, and this is only what I can advise to anybody now eager to learn with the Prolenium Revenance portfolio, and this goes for every product, is that before you inject into the patient, really understand how much pressure you have to apply for each product with a 31, 32, 30 gauge needle, because it is differing, and especially in the lips, we need to have a precision. So there's something I would test, just a little bolus before you go there.
And the good thing is you don't need so much product, because the products are so amazing. They're projecting so like the Ultra Plus and the outline. And if you position small amounts, you create, it's like painting. It's beautiful.
All right, Olga. Hannah, anything else to add from Prolenium side, or
I just wanted to repeat that because we had a lot of requests about this, but yes, this session was being recorded and everyone will receive the replay in 2 days for everyone that registered to the webinar. So thank you again to you both for your amazing presentations. I think everyone learned a lot tonight. And we will hopefully see you again for a next webinar soon.
Hope so too. Thank you so much, Hannah, and Olga. Congratulations on those amazing clinical cases.
Always so to do sessions with you. It's a pleasure, Konstantin. Always
Likewise.
nice. Thank you.
Bye.
Bye,
everyone.
Bye-bye.